All right, so the nervous system effects of morphine is that opiates eventually will cause hypoventilation if you're given high enough doses. When you do that, when you cause the hypoventilation, the person will become hypercarbic. And when you get to hypercarbia, then you increase cerebral blood flow, which then increases ICP. So opiates are dangerous in the sense that they do cause an increase in ICP pressures if you allow them to cause the person to hyperventilate, okay, especially morphine. If you have an absence of hyperventilation, which means you put the person in mechanical ventilation, you basically normalize the cerebral blood flow, and their ICP will actually fall if you actually decrease the cerebral blood flow by increasing and hyperventilating them. So morphine is really not contraindicated in somebody who has head injury as long as you're aware of that you got to ventilate that individual. If the other downsides to giving narcotics like morphine to a person with head injuries is that it affects wakefulness and increases the risk of vomiting and having nausea. It also produces a pinpoint pupils, of course, which can confuse the picture of the examination, and will cause a decrease in the ventilation like we talked about before. Morphine can cause also skeletal muscle rigidity, especially when you give it in very high doses, and can actually make the person almost impossible to ventilate. They get all this chest wall rigidity when you're trying to ventilate them. It's like ventilating a rock. And that can happen with also the synthetic narcotics, as you'll see, and I'll tell you a story about one that happened to me, to one of the CRNAs I was working with. Okay. Sometimes it actually can become impossible to mass ventilate, and you have to give that person muscle relaxants so you can ventilate. If you look at from who gets the most rigidity, fentanyl is by far the most effect, followed by remifentanil, and morphine's on the lower end. If you give fentanyl, it can also cause muscle rigidity, but it doesn't occur at the chest wall. It actually occurs at the larynx. It can cause a laryngospasm on individuals and makes them impossible to intubate. Makes it impossible to ventilate until you give them muscle relaxant. If you look at the biliary tract, all the narcotics will basically cause the biliary tract to spasm, and it causes an increase in intrabiliary pressure. The downside to that, of course, is that if you're doing an intraoperative cholangiogram and you're giving this drugs beforehand, you can actually mimic what looks like a stone when in reality there is no stone. So I would be very cautious if you have a surgeon who's doing a laparoscopic cholecystectomy with an intraoperative cholangiogram. I make sure I don't use any narcotics at all until the cholangiograms. Okay, you just be cautious. If you look at what causes this biliary spasm more so than anything else, it's fentanyl, which is what we use mostly in the operating room, followed by morphine. Meperidine has one of the lowest amounts, and sometimes is used, and it can be effectively okay. During surgery, opiate-induced spasms may be incorrectly diagnosed as a stone, which is, of course, not something you want to do. If you want to reverse biliary spasm, you can give Narcan or Loxone. The downside to it, of course, you reverse all the analgesic effects. So instead, what we tend to use is we give people glucagon. Okay? We give usually 2 milligrams IV. It reverses the opiate-induced biliary spasms without reversing the analgesic effects of the narcotics. So GI tract, opiates can produce spasms of the GI smooth muscle resulting in constipation, biliary colic, and delayed gastric emptying. And there's, of course, an increased risk for potential aspiration. It increases the biliary pressures, occurs with gallbladder contracts against the closed or narrowed sphincter of Oddi, and it gives a peripheral acting opiate antagonist may actually prevent these effects as well. The downside, of course, is you're reversing narcotic benefits. Nausea, vomiting can also be a problem. It's caused by direct stimulation of the chemoreceptor trigger zone in the fourth ventricle in the brain. Opiates can actually act as partial dopamine agonists in the chemoreceptor trigger zone. So you have to be very cautious about giving narcotics to people with Parkinson's disease. Certain agents are more so than others, but you just be aware of that. Morphine can cause nausea, vomiting by delayed passage of intestinal content as well, which means that the intestine just can't get rid of stuff, and as a consequence, increase the risk of nausea and vomiting by distension of the GI tract. One of the bad things of giving long-term morphine to somebody is you can get a megacolon. The colon just begins to dilate and gets bigger and bigger and bigger, and it gets ischemic, and the person eventually ruptures this huge colon. Or you have to go in the operating room, or you go to endo first to try to put in a tube in to decompress the colon. If that doesn't work, then you got to go in the operating room and cut that section of the colon out. GUIs, morphine can increase the tone and peristaltic of the ureter, and this causes urinary retention in people. If you look at the cutaneous, this is a classic picture of morphine. I've seen this more than often. Everybody says it's an allergy. It's not. It's a histamine release. Okay? So it's non-allergic reaction. This person should not be labeled as being morphine allergic. They're not. They're just causing histamine release when that drug was injected in the IV. That veins release histamine directly into the venous area and cause that streaking up the arm. Okay? Sometimes you also see skin, face, neck, and upper neck. The chest will become flushed and warm because the cutaneous vessels will dilate. Placenta may also be something that's an issue. Morphine will pass through. Basically, the placenta is an active barrier. As a consequence, the baby can get exposure to morphine or wherever else you're giving. The lipid-soluble agents are even more so. So I don't give narcotics until the baby's out. That's my rule. And it works just fine. So, but if you give narcotics beforehand, the fetus may get affected, and as a consequence, of course, the kid may need resuscitation with giving Narcan, which is something you really don't want to do. Morphine causes greater neonatal depression in the neonate than meperidine. It's basically immature blood-brain barrier of the baby. So physical dependence may also result as a consequence of chronic exposure by the mother. Drug interactions you got to be very careful with. Some opiates may actually exaggerate by amphetamines, phenothiazines, MOA inhibitors, and TCA depressants. Example of that is meperidine and MOA inhibitors. You don't want to mix the two. You actually get a very bad effect called the serotonin effect, which we'll show you in a minute. Tolerance will eventually develop, and physical dependence. The cross tolerance develops between all opiates. So if you're giving somebody high doses of opiates, when they come to the operating room, they're going to be tolerant to your opiates, even though they're different. Okay, and so you got to be aware of that and not chintz on the narcotics. If you have somebody who is a big-time heroin addict, you're going to notice that the fentanyl that you're giving is almost like you're giving water to the patient. You give 1,000 micrograms of fentanyl at the end of the case, and the person's still breathing 32 breaths per minute. That means you got to get another 1,000 mics and keep giving it until you get the response that you want. You want to see the respirations coming down because that means you're then binding to the receptors. And you got to learn not to be afraid of that. If you don't, when the person wakes up, they're going to be screaming. And even if you do give enough narcotics, they still may scream because they have so much down-regulation of the receptors that the opiates are just not going to work. What we do know that upregulates the receptors will be things like ketamine. Ketamine, because of sigma binding, actually upregulates the opiate receptors and may actually enhance the activity of the opiate receptors. So that's another thing to consider giving. But it's in small doses at the end of the case. You're not giving an induction dose. Tolerance usually takes only 2 to 3 weeks to develop, so it doesn't take long. And then physical dependence on morphine usually takes about 25 days, but you still get some degree of physical dependence only after 2 days. Some people are very sensitive and start going to withdrawal as soon as you stop taking the medication. What withdrawal basically means is that person develops symptoms of like yawning. They start getting sweating. They start crying. They get what's called coryza, which is like a head cold. Their head becomes flushed, and they're pretty miserable. They get restlessness and insomnia. They get severe abdominal cramps, nausea, vomiting, diarrhea. And that can reach all the way up to 72 hours and then begin to decline. And the withdrawal can be so violent that you can actually die from it. And it's not a joke. So some people actually will give methadone to people like this to try to get them through this phase so they can then take them off the methadone more fully. We also add to prevent withdrawal by adding clonidine. Remember, clonidine is a central acting alpha-2 agonist that helps with the withdrawal symptoms by shutting off the sympathetics from firing. Withdrawal can actually just persist for 7 to 10 days. With morphine, I've seen it persist up to 32 days on morphine in somebody. So it can be a real nightmare. Especially heroin was the other one that was really difficult to get people off. Opiate overdose, principal manifestations of opiate overdose is depression and ventilation. Usually gets slower breathing frequency and actually progresses to apnea. The person will develop symmetric and myotic, which is severely small pupils. and unless they get it to a severe hypoxemia, which then they'll get mydriasis. By that point, the game's over, so it's usually pretty late. Skeletal muscle paralysis and upper airway obstruction can also occur. Pulmonary edema also may occur. Usually, if because of the upper airway obstruction, will cause what's called negative pressure pulmonary edema in these individuals. The triad for opioid overdose is meiosis, hyperventilation, and coma. Treatment of opioid overdose is mechanical ventilation. You just got to put a breathing tube in it and basically mechanically ventilate them. Or you can give the opioid antagonist. Okay? I'm very leery about giving this stuff unless I have to. Narcan is, naloxone is not benign. We usually give it anywhere between 4 to 2 milligrams every 2 to 3 minutes as needed. What I tend to do is I dilute the stuff down and start giving it slowly. As long as I'm ventilating, the patient's okay, then I start just giving it slowly. What my desired effect would be for the person to open their eyes and breathe, but still get comfortable. If I punch it too hard, the person sits up, looks at me, and then begins to start screaming. And at that point, bad things happen. And I've seen people do this. They think it's, they have this kind of weird warped thought that because somebody's a narcotic addict, well, I'm going to teach them how to really reverse this stuff. So they take the stuff and give them a whole whopping dose of reversal. Well, yeah, they're going to wake up. They're going to wake up so fast that their heart rate's going to go to 140. Their blood pressure is going to soar to 200 to 300. Okay? They're going to hemorrhage into their eyes. You'll see their conjunctiva literally turn red from the blood flow going to their brain. They may stroke out on you. They may have a heart attack. They may go into VFib attack. Not smart. Okay? So I've seen people do this, and I've watched it, and I go like, these guys are idiots. And I step back. It's like, I don't want anybody doing this. I'm not ever doing this. So I said I titrate it too slowly to have the effect I want. And if I need to, because the narcotics can some be very long-acting, like morphine and heroin are very long-acting, then you need to repeat the dose about every 20 to 60 minutes. So once you give somebody Narcan, guess what they should go to? Intensive care unit. They can't go anywhere else. Or the recovery room where they can be watched very closely on 1 to 2 basis. You cannot send these people to the floor. If you see no response after 10 milligrams, you got the wrong diagnosis. Okay? Yes? You can. If you do that, then the person will go apneic on you again. Because Narcan doesn't work very long. So by the time it begins to wear off, morphine maybe start kicking. Then you're playing seesaw. You're killing the patient and trying to save them. So just don't do that. Just give a little bit at a time. Be patient. As long as you're ventilating, it's nothing to worry about. As long as you can ventilate the patient, it's no big deal. As they come out of it, they'll look up at you and they go, okay. And then, what the first thing they'll tell you? Man, you killed my buzz. Sorry, I saved your life, dude. I had several people that I saved their life that way. And I brought them out slowly, but they really didn't like me because I didn't kill their buzz. It's like, great. So I'm sure they end up dying later on from doing the same stupid stuff, but people just don't learn. You can actually give a Narcan infusion that can reverse some of the bad effects, the itching. You can give very low doses of Narcan. The way we used to do is you would put 1 amp of Narcan into 1,000 cc's and then run it at 15 cc's an hour. If you do the calculations, it's a very low number. But it takes away the nausea and it takes away the itching nose without affecting the narcotics at all, the actual narcotic effect of the pain. So, but the acute withdrawal is really impressive. They do come right out of the bed and they're like absolutely crazy. So that's something I would recommend. Codeine is also a naturally occurring narcotic. It's structurally similar to morphine. What makes codeine more beneficial is that it has a methyl group attached to it, which makes it a little bit more resistant to breaking down by acidic environment of the stomach. So it is orally effective. So when you give it to somebody, it has a half-life around 3.5 hours. It's a great antitussive when you're giving it 15 milligrams dose. And when you look at equivalencies, codeine is really not powerful. It's in the sense that it doesn't really knock out severe pain. Codeine and aspirin are equivalent. At 60 milligrams of oral codeine, you're equivalent to 650 milligrams of aspirin. So that's pretty impressive in the sense that aspirin is pretty strong. 120 milligrams of IM codeine is actually equivalent to 10 milligrams of morphine. So you're looking at codeine is actually 12 times less strong than morphine. Okay? The side effects include nausea, vomiting, minimal sedation, constipation. It's not really recommended to give IV because it has significant histamine release with associated hypotension. That's why almost nobody gives IV codeine. Hydromorphone is another agent that's also naturally occurring. So it's called Dilaudid. It's 8 times more potent than morphine. I like this agent for postoperative pain. We use it quite a bit. It has a shorter duration of action, which is kind of nice, so it can wear off if you get too much of it. It does cause less euphoria than morphine. It does have a little bit more sedative quality, which is the downside to it. But when you have somebody who's really anxious, covering them, and it's kind of jittery, giving them Dilaudid works better than morphine. And it takes them and sedates them down a little bit more. It's basically very similar in its uses and side effects to morphine. And we tend to give it IV for postoperative pain. Usually get boluses of 0.2 milligrams to 0.4 milligrams IV. And then the maximal dose usually is around 2 milligrams IV. And that's what we tend to use quite a bit. I like this drug, and I use morphine a lot too for postoperative pain. The nurses are pretty comfortable with using it. You don't want to use the short-acting stuff like fentanyl because it's too short-acting. This stuff is more for long-acting. And most nurses are really cautious in the recovery room. They don't give big boluses like we do. We tend to be the gung-ho group. We tend to go with all feet in by giving way too much narcotics sometimes. The good thing is that by our short-acting agents, and we have people intubated, there's nothing bad's going to happen. In the recovery room, bad things can happen if you give too much of the stuff, and you got to be aware of that. Let's go on to the synthetic narcotics. Synthetic narcotics have been a godsend to anesthesia. They've really dramatically changed how we deliver care. Morphine's biggest limitation is its histamine release. But with these synthetic narcotics, you don't have that effect as much. The number one agent that came out right before World War II was meperidine. Meperidine was produced by the Germans right before World War II because they knew that during the war, which is World War II, they knew that they were not going to be able to get any opiates from Afghanistan. Because during that time period, who controlled it? British. The British controlled Afghanistan right before World War II. And just like India, Afghanistan, all that area was controlled by the British. And the British controlled all the opium trade. That's why they had a big problem in China with the opium, which is another thing that also helped start World War II. It's another topic completely. But the politics of narcotics is actually very interesting. And it continues to be a problem in the world, to say the least. Anyways, synthetic narcotics were produced was meperidine. Meperidine was unique in the sense that it added something to it. They decided that one of the downsides of giving somebody morphine is that it causes bradycardia. So they wanted to make sure that this narcotic would not only cause the person to be comfortable, but also increase their heart rate. So what they added to it was they added atropine. Atropine is a component of meperidine. So it's one of the few narcotics that actually will increase heart rate. So it's a really good narcotic. If you have somebody who's in moderate pain, who is complaining, that the nurse calls you and says to you, look, I've got a patient who's bradycardic here. Which one do I use? You wouldn't want to give morphine. You'll get more bradycardia. You wouldn't want to use fentanyl because you can induce more bradycardia. But Demerol or meperidine would be the effective agent. It would actually increase heart rate and maintain that person. So that would be the better choice. All the drugs from meperidine down, okay, fentanyl, Sofenta, alfentanil, remifentanil, are all derivatives of meperidine. They're all derivatives. Okay, so that initial synthetic, and these are called phenylpipridines, they're all the same family. Now, meperidine, also known as Demerol by what most of us know, it's a synthetic opiate agonist. It binds mostly to kappa. It has some mu receptor activity as well. Fentanyl, Sofenta, alfentanil, remifentanil are analogs. And structural meperidine is similar to atropine. So right here, this is atropine. You can see this molecule looks exactly the same as our friend here, meperidine. Okay? So structurally, it does have atropine, which acts like an antispasmodic, but it also increases heart rate nicely. Meperidine, pharmacologically, is absorbed via the oral route. It's about a half as effective as IM route. Potency is about 1/10 as potent as morphine. So 100 milligrams of meperidine is equivalent to 10 milligrams of morphine. So you're giving quite a bit of amount. So most of the time when people come out of the operating room, the other thing you'll use as an antispasmodic or anti-shivering will be Demerol. And we're only giving 12.5 milligrams IV of the Demerol for that. And it works very, very well for that. So it's a primary agent that we use for patients that are shivering. The duration of action is pretty prolonged. It's 2 to 4 hours, which has a little bit shorter duration than morphine. In equal doses causes much sedation, euphoria, nausea, vomiting, as morphine does. Pyridine tends to be 60% protein bound. Hepatic metabolism is extensive, with 90% of the drug metabolized to a side product called normepyridine. Normepyridine, if it accumulates in you in high enough amounts, will cause seizure activities. So that's one of the that's one of the downsides of meperidine, is this conversion to normepyridine. The other side of the other thing that's produced is meperidinic acid, but the one that everybody asks you on a test is normepyridine. If you know meperidine, all you got to just ask is put no in front of it, or nor in front of it, and you know what that's the one that causes seizures. Okay. Urinary excretion is the primary route of elimination, and it's pH dependent. So if you alkalinize your urine, you actually increase. If you acidify the urine, you can actually speed the elimination. 25% of it is eliminated unchanged. Renal failure will cause a risk of this normepyridine compound to accumulate in your body and cause seizure activities. So really, Demerol should be avoided in patients who have renal failure. Now, can you use it as a single dose agent in recovery of a person shivering that has renal failure? Absolutely. Just don't give a secondary dose. Okay? And so norepinephrine takes a while to accumulate. You're looking at maybe a day or two, so it doesn't happen right away. Okay? The half-life is norepinephrine is very, very long. It's 15 hours. So it takes up to 35 hours for the patient to get rid of it if it has renal failure. That's a long, long time. Potency is half as potent as meperidine, but it still acts as an analgesic. So normepinephrine does still have potential activity. It does cause CNS stimulation, myoclonus, and seizures can occur after prolonged administration, especially in renal patients. The other thing you'll get is also delirium with hallucinations and confusion. And you look at the elimination half-life for meperidine is around 3 to 5 hours versus norepinephrine is about 15 hours. Meperidine's clinical uses is that it's analgesic for labor and pain and after surgery. It's a good choice when the patient has bradycardia pain because of atropine-like structures. It's also effective in controlling postoperative shearing. We think this is due mostly to the stimulation of kappa receptors, which has about 10% of the drug's activity. And the other drug that actually will have a high amount of kappa binding is what's called butorphanol, which is an agonist-antagonist. That's why we don't use it, because if you give an agonist-antagonist and the person has a lot of pain, what happens when you add morphine? Nothing. It doesn't work. Okay, so don't give agonist-antagonist ever unless you already know that the person is really comfortable. Now, if the person is really comfortable and you give them an agonist-antagonist, you can actually make them uncomfortable again. Now you're really stuck, because now you've given a partial antagonist to this individual. Should you give an agonist more to get that person comfortable? And if you do that, you may push them over the edge and make them apneic, especially about 35 minutes later. So be very cautious. Morphine used to be used extensively for treatment of diarrhea because it's constipating, but Demerol doesn't have that effect. So it's not useful to treat as diarrhea, and it has very little antitussive effects versus codeine. The side effects at high doses causes direct inotropic effects, which is not good, and it can cause histamine release, but you're really giving a huge dose of meperidine at that point. You're looking at 500 to 600 milligrams of meperidine. That's a pretty high dose. I've never given that. I don't use it in the operating room. I really use it for post-operative issues, and I don't recommend it for intraoperative use most of the time. They'll use it in OB quite a bit in pre-op, which is fine, but It's not the best drug. It doesn't make women comfortable. If you ask them if they're comfortable, they say, I really don't care, but it still hurt. Okay. All right. So you don't really, it gives you more euphoria than it really affects the pain. You get a little bit more frequent hypotension in comparison to morphine. It causes more ventilatory depression. It rarely causes placenta, so baby can definitely get affected. The only beneficial thing about it is it's less constipating. It does cause a little bit less urinary retention, and also it causes less biliary spasms in comparison to all the other agents. And the atropine-like structure makes it develop a different eye effect. Morphine and all the other narcotics, fentanyl, remifentanil, will cause meiosis. This is the only agent that will give you mydriasis. And so it actually will dilate your pupils. So I've seen that happen one time, and the people were freaking out. They're saying, oh, the person's going to herniate, the person's going to herniate, because the guy was somnolent, because they gave him so much Demerol. They gave him 100 milligrams of Demerol, which is a little bit of a whopping dose. So I looked at him and said, no, this is just the atropine structure in the actual Demerol. So it can cause that effect. So, now, the bad thing about MAO inhibitors was found out by what's called the Libby Zion case. The Libby Zion case is actually a very famous case that really changed medicine tremendously. It was a young lady that was 18 years old. She was in college. She was suffering from severe depression. And she was brought into the hospital because she had suicidal ideations and wasn't feeling well, was having increasing bouts of confusion, nausea. So they brought her in and to further examine her, and it appeared that she was getting rigidity. So she was actually on MAO inhibitors. They didn't understand that part of the effects of MAO inhibitors sometimes is you will get cogwheel rigidity and problems like that. And unfortunately, the person who was taking care of her that night was an intern who then gave her more Demerol, gave her meperidine. And meperidine will induce what's called serotonin syndrome in people that are on MAO inhibitors. What it basically causes is autonomic instability, severe hypertension, tachycardia, diaphoresis, hyperthermia. That's what ended up killing Miss Zion. She was found several hours later after they gave her the Demerol, after it seemed to calm her with a temperature of 107, 109 degrees. She subsequently died from the hyperthermia. So don't give people that are on MAO inhibitors Demerol because of this effect. Okay? What MAO inhibitors basically do is that they cause the inhibition and conversion of the actual neurotransmitter, norepinephrine, and it begins to accumulate. So when you give these people Demerol, it accentuates that effect even more, and you begin to release high amounts of your neurotransmitter, which causes the high fever, tachycardia, and hypertension, and also will cause increased levels of agitation and confusion. Now let's go on to the other ones. Yes, sir. Say again? Yes, you have to be careful with Prozac as well. That's the other. Right, SSRI is the other one, right. But it's not an MIO. It also, you should be careful with them. Will it cause the same serotonin effect? Not likely with small doses. But, what killed Libby Zion was they gave her too big a dose of Demerol, and then they didn't watch her. Because if they picked up on it earlier, they would have been able to get her reversed out of the hyperthermia. It's something that's very unlikely to happen in our recovery rooms because we're watching them so closely. But something to definitely not give anybody MAO inhibitors that have Demerol. It's not appropriate. As for the SSRIs, you can get into this problem as well, but the frequency rate's it's lower. It's not zero, but it's not. It's just lower. So I would still recommend sort of avoid it unless there's a really good reason. I think for giving it for somebody who's getting muscle spasms, giving a little bit of more Demerol, just 12.5, should be no problem. Okay. Synthetic opiates, we'll move on. These are the manufactured ones after meperidine. The ones you look at is fentanyl, sufentanil, alfentanil, and remifentanil. The major difference is that they're very potent because these agents are very lipid soluble. Okay? And you're going from one to the next, and the one that you're the most lipid soluble is the one that acts the most potent, and it has the shortest duration of action. Okay, structurally, fentanyl, also called sublimase, which nobody calls it sublimase, everybody calls it fentanyl, is 100 times more potent than morphine. That's pretty potent. Okay? It's a single IV dose. Normally we'll give 50 mics at a time. That's what our normal dosing is when we're in the operating room. We usually don't give 100 mics to 200 mics at a time unless we're trying to have a certain desired effect. Most of the time what we're doing in the operating room is we're in the middle of maintenance phase, we'll add 50 mics and see how the person does, just to suppress some of the painful stimulus from the surgeon. It has a very, very rapid action, more rapid than morphine. And you're looking at the site equilibration time, which is basically, site equilibration is where the medication works, which is in the brain. So this medication, instead of taking 15 minutes to peak, this medication only takes 6 minutes to peak and really peaks pretty hard. So it penetrates into the blood-brain barrier very, very fast. If you give enough of it, you can actually slow EEG down quite a bit. Okay? The other thing that fentanyl does is it also has a very short duration of action. The short duration of action is due to its rapid redistribution because it's so lipid-soluble. It goes into the brain and then it comes out. Okay? And that's the benefit of it. It works fast, but it comes off fast. So if you need more, you just keep adding more till you get the effect that you want. Okay? It has greater lipid solubility than morphine. It has greater potency, more rapid onset. Redistribution into inactive tissue is what terminates the action. So it gives it a very short duration of action. And it goes to inactive sites such as fat and skeletal muscle. And the other place where you find a lot of fentanyl in very high concentrations is where? Stomach lining. It becomes ionized and trapped in the stomach lining. It also has extensive lung inactivation. So the lungs in the first dose removes about 75% of the drug. So that's pretty impressive. Okay? Saturation eventually happens, though. If you give enough fentanyl, it's just like giving, and we'll talk about this next week on barbiturates. When you give enough barbiturate, you eventually overwhelm the fat stores, and it begins to accumulate. This is the same thing. This agent is so lipid soluble that it begins to stay in the fats and begins to store enough that if you give it enough, it begins to saturate. And then it redistributes back into your bloodstream to the brain, knocks you out again, and keeps you asleep. So fentanyl, is in a bad way, is once you start giving it in long durations, you can have it to expect to become saturated. Now, metabolism is pretty important. It's an N-demethylation, just like morphine is. It produces what's called, and also mypiridine. So all these agents are being broken down by the liver. It's basically structurally related to norepinephrine, and norfentanyl is excreted in the urine. The elimination half-life is a little longer than morphine because it's got a larger volume distribution because it's greater lipid stability. But the clearance of both opiates are very similar. In the elderly, you get a prolonged elimination half, so you decrease clearance, decreases in hepatic blood flow, and decreases in albumin production can all lead to an increase in fentanyl duration of effect. If you look at the context-sensitive half-time, we talked about this before. Fentanyl is not a good agent for long durations because you can see after just an infusion over 120 minutes, the actual concentration or the time, you saturate the tissue so quickly that your recovery time becomes very prolonged. Okay? So fentanyl, if you're using it in the ICU, you should only use it for about 48 hours and then shut it down to give them a day. Because what it's going to do is going to take them a day to get the stuff off. And then you can restart it again once the person begins to wake up again. Otherwise, the medication keeps accumulating, and then when you shut it off, it takes 2 to 3 days to wake them up. Okay? It does do saturation effects. All opiates have a decrease in plasma concentrations on initiation of cardiopulmonary bypass because what they do is they bind to the plastic. So actually fentanyl has a greater effect because a significant portion of the actual medication binds to the surface of the actual circuit. When you give fentanyl 50 mics per kilogram over 10 minutes, in contrast to morphine, does not cause histamine release in any patient. So fentanyl is a much safer agent, and that's why we use it in hearts, because it doesn't cause a histamine release. Okay? Opiates with large volumes of distribution will have a more stable plasma concentrations like alfentanil and fentanyl, which we'll talk about in a minute. Clinical uses, we usually use a low dose, 1 to 2 mics per kilo IV for analgesia. So if you have somebody who's 100 kilograms we'll give them 100 mics in single dose, or we'll give them a lower dose at 0.5 mics per kilo, which is usually 50 mics in the adult population. And that works pretty well. It's better to give smaller amounts because you can always give what? More, okay? So when you have somebody who's breathing at the end of the case and they're breathing, let's say 35 times a minute, should you give them 50 mics? Yeah, go ahead. But if they're breathing at 25 breaths a minute and you want them to be down to around 20, you give them 50 mics. And the answer is no, and 25, because you might get burned. Somebody's going to be very sensitive, especially older people. So the 50 mics general rule is for somebody who's healthy, in good shape. Otherwise, reduce your dosages so you have the effect that you want. Now, if you want to basically add it to the MAC bar, you need to be at 1.5 mics per kilo per minute to get the MAC bar effects, so or higher. If you want the laryngoscopy response, you usually have to give at least 10 mics per kilo IV. That's a big, whopping dose. And if you do that to an adult that's elderly in this county, they won't wake up till tomorrow, so they definitely didn't feel the laryngoscopy, but they don't feel anything else either. So be careful. And if you're taking care of 30-year-olds, 10 mics per kilo, it's not going to be any problem. They'll tolerate it just fine. But you're taking care of an 80-year-old, different ballgame. High doses are for surgical anesthesia, which is 50 to 100 mics, 150 mics per kilo per minute. So what we would give is we would give 100 mics per kilo per patient. So in other words, we give it 2 cc's per every kilo of that patient. So the patient weighed 100 kilos, we would give 200 cc's of fentanyl. 200 cc's, that's 60 cc vials, boom, 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 boom. We push them, push them, push them, push them. Okay? And people they'd be absolutely rock solid during the whole case. At the end of the case, they were still asleep. And they'd still be asleep till the next day. So people were not getting extubated for at least 24 hours on the vent, at the minimum. Then they would wake out of it like they were like a dinosaur coming back to life. Okay? The new doses, of course, we're not anywhere close to that. We're maybe giving a total of 20 cc's a whole case, and people are waking up within 6 hours after the case, and they do much better. Now, preemptive analgesia is, of course, very important. Giving these narcotics is give this stuff early. Pros and cons, advantages of stable hemodynamics, because it has no myocardial effects, lack of histamine release, and it does suppress the stress response to surgery. Disadvantages is that it can sometimes fail to prevent sympathetic stimulation to very painful surgical stimulation. And by that, I mean cutting your sternum open. Okay? Almost everything else, cutting skin, the person's not going to respond. Even breaking through a rib, it's not going to respond. You cut through the sternum with a saw, and they'll respond. Okay? If you've ever seen the actual sternal saw go off, you got to go like, oh, that hurts, just looking at it. So it's pretty impressive. So even with that, it won't work completely. And the other downside is that these people appear to be asleep, but they're not, and they actually can recall. And they'll talk to you and tell you about how it didn't hurt, but I didn't like that you didn't know that I was awake. Postoperative respiratory depression can also be a big problem, of course. That's why we keep people intubated for 48 hours. There's actually different forms of fentanyl. There's the lozenges, which is something that we use for kids. It can deliver 5 to 20 mics per kilogram of fentanyl. In children, you give them preoperatively 10 mics, usually 10 mics per kilo PO. So if you have a 20 kilogram kid, you're looking at 200 mics. Okay? And you give the kid the lozenge, suck on it, lollipop, and it was timber, boom. Okay? If you gave them a little too much, they would go apneic and die on you. So it's the downside to it. Okay? So you got to be really aware of that. You got to watch them. You can't just give them a lozenge and think it's a lollipop and walk away. You got to have somebody always watching that kid. And the other thing is they will timber. They'll be walking around and they'll hit the ground before their parents realize it. So once you give them the stuff, you really sort of have to corral them and make sure that they're not going to hurt themselves. They also may get nausea and vomiting refractory to droperidol, which is a downside to this as well. Most places have gone away from this because now the parents have become concerned that they'll associate narcotics with lollipops, and they'll begin to you know, they're doing all this weird stuff that they're sucking on things. I don't know what the name of it right now is, but it's one of those free basing. I can't remember that. Anyways, I'll remember that. But it has nothing to do with fentanyl, but people became concerned that we showed them the way. I don't think so, but whatever. Transdermal fentanyl is the other thing that is being used a lot of. Transdermal fentanyl is a really great way of delivering fentanyl for long-term, for chronic cancer patients. What you have to know is these people will come in with this stuff on. And what it basically does, it has to do with how much delivery is based on surface area. You basically can push around 25 mics per hour per 10.5 centimeters of surface area. Time to maximum concentration is about 35 hours, so once you stick the patch on, don't expect to work right away. If you're having somebody in severe pain and you add the fentanyl patch, you've got to start getting them comfortable IV first, and then you let the patch work. And once the patches get into a certain level, it begins to make these people comfortable. And you can actually see this is a 75 mics per hour Duragesic patch. That's pretty impressive. That's a pretty big dose of fentanyl continuously being given to that individual. The maximum duration of these patches can last is about 72 hours. And you need to change the site. Don't leave it on one site. You've got to actually switch it to another site. There is risk for apnea and respiratory arrest in these individuals. There's something new in the market, which is, I just wanted to show you because I saw this the other day. They actually have a housing with an on-demand button. Wow. You press it, and it gives you an extra 25 mics per hour for that car, which is pretty impressive. So most of the time, people just have these patches. Okay? So what do you do? If you get somebody like this, how do you figure out what they're on? And do what's called a conversion. Okay? So if the person is, let's say, on oral morphine, and they're doing 400 milligrams of oral morphine per day, okay, which is a pretty heavy dose. And you want to switch them over to a Duragesic patch. Okay, you go to 400. Let's see the next one. Okay, this is the actual equal analgesic potency conversion, IAV versus PO rates. So and it compares it to the actual where are we at now? This is Dilaudid morphine. This is what it actually. Then what you do is you go to the next one, which is this one. This is what I want to show you. This, if you're on morphine, okay, this is easy. And I tell you that you're at 400, then my Duragesic patch that I should put on this person is 100 mics per hour. So this is actually pretty easy. Okay, and it can be helpful to know if somebody's on a lot of morphine, you can actually then possibly put them on a patch before you put them to sleep, so when they wake up, they're comfortable. Okay, because what you don't want to have is somebody who's on the high doses of morphine withdraw from it after surgery, and then you're fighting it. So Duragesic patches can actually help you transition in that way. Fentanyl's side effects is very similar to morphine. It has the same kind of problems. But what's interesting about fentanyl is it has a double ventilatory depression peak. Okay, it has a peak of initial dosage, and then about 45 minutes later to 90 minutes later, you can get a secondary peak. Now that's kind of strange for a drug, right? I mean, you just gave a drug, and why should it get high again? Why should it redistribute? And the answer is where does the drug go? And the way that the medication terminates in its action is that it goes to other lipid-soluble lipid sites. And one of the places it goes to is the stomach lining. And when it goes to the stomach lining, it sort of lives there in its very highly ionized state because of the pH. But if you give that person Pepsid, okay, or you begin to increase blood flow to the GI tract and that pH begins to drop off and some of the medication now passes into your intestinal tract, because now it's sort of dissolved into your gastric pH. Then when it gets realkalinized, what happens? It gets reabsorbed, and now it's unionized. It gets to your brain and has the effect that it wants. Okay? So sometimes you can get that gastric mucosal, what's called ion trapping effect. The other thing that's also, remember we told you about fentanyl, is that 75% of it is broken down, or at least bound by the lung. Well, if you increase blood-lung flow, what happens to that extra fentanyl that was sitting there? It gets reabsorbed. So that's the other reason. It's called a washout. So the washout from the lungs as ventilation perfusion relationships are reestablished post-op can give you that secondary peak. So there's really two reasons. And then as a consequence, you can get apnea as a consequence. Now, have I seen that very often? And the answer is not really, unless I'm giving really high doses of fentanyl. And most of us don't give that much. But if you're giving a person, somebody, let's say 1,000 mics by the end of the case, that's pretty high. You can expect this kind of effect, and you've got to make the nurses sort of aware of this problem. A lot of recovery room nurses don't know about this. They do find out about the hard way, and they go like, why did this happen this time where I give morphine to somebody and nothing happens? And there's a secondary peaking effect, so that's happening. Cardiovascular effects is you don't get any release of histamine, so hypertension is really unlikely. Carotid sinus reflexes are bradycardia is more prominent with these agents. So one of the things that we add with fentanyl is we usually add papillon. Seizure activity may occur, but it's not really seizure activity like the normal seizure activity where it's, you get seizure changes on EEG. It just appears like seizures, but it's really most likely myoclonus or skeletal muscle rigidity. You get intracranial pressure can also increase. It's, you get a moderate increase in the ICP for patients with head injuries without increases in PaCO2, which is interesting. So this is one that you're normally ventilating. So if you add fentanyl, sufentanil, to somebody who has elevated ICP may not be the wisest thing. The question is, how does it do this? And the answer has to do with the actual out-of-regulatory mechanism. What you're doing when you're giving fentanyl and things like sufentanil is you're suppressing the out-of-regulatory mechanism. So instead of that person having the blood vessel dilate at a certain CO2, it doesn't do that. Instead, it dilates too much. So that person's mean arterial pressure falls, but their actual cerebral blood flow increases in that individual and causes increases in ICP. Excuse me. Drug interactions with fentanyl is you have potentiation of metazolam or propofol. And I've been burned with this several times. We were giving somebody Versed and fentanyl. Everything was fine. And then the patient started moving around a little bit too much. I said, I'm going to give 1 cc of Diprovan and I'll be fine. You know, it's just 1 cc. Sure enough, I gave 1 cc and the guy was apneic for 15 minutes. This stuff can be really, really synergistic. So be careful with it. Don't be giving a lot of Versed and fentanyl together and then add propofol. And you're going to find out the hard way what's going to happen. The effects of opiates and benzodiazepines on respiratory depression is significantly synergistic in action. Pre-induction doses of fentanyl is associated with reflex coughing. It's not good to give patients fentanyl right before you put an LMA. I don't recommend it. I've seen people do this all the time and they wonder why the person's coughing all the time on them versus the next person that comes in the room and does induction with them doesn't add fentanyl, and the LMA placement is really kind of simple. You get no coughing at all. They don't associate the fentanyl with the coughing, which is what's inducing it. It's not the LMA placement. Sufentanil is the next drug we're going to talk about real quick. It's a structure related to fentanyl. It's actually 5 times more potent than fentanyl, and it's 5,000 to 10,000 times more potent than morphine. That should impress you. Okay? It's a pretty potent drug. What we actually do with Sufenta is we give 5 mics at a time. It's all you need. Okay? I've seen people give 50 mics of Sufenta, and they think it's 50 mics of fentanyl. No, it's 10 times more potent, okay, than fentanyl. So all of a sudden that person is like, that would be like equivalent of giving that person 500 mics of fentanyl. Big dosage difference, okay? So what Sufenta comes in is 50 mics per cc. So, and we usually get 1 cc vials, and we take it and we dilute down 1 cc and 10 cc's of saline to get the 5 mics per cc. That's how I use Sufenta. I don't like Sufenta because it's so dang on potent, okay? But it's great for certain procedures. Much higher doses are required to precipitate seizures, which is kind of nice. And it does cause a little bit less ventilatory depression and give you a little bit longer postoperative analgesia. The effect site equilibration is very rapid because it's highly lipid soluble. It's actually very faster than fentanyl. Fentanyl is around 6.8 minutes. The actual effect site equilibration for fentanyl is more potent, 6.2 minutes. Termination of action is really basically by redistribution, so it's actually got a short termination of action. It can accumulate over time, which gives you a prolonged effect. The high lipid solubility is a problem when you have patients that are morbidly obese, that this drug accumulates more in them, so it can become a problem. It does have extensively high protein binding. which is 93% of this drug is protein bound, versus the actual protein binding of fentanyl is only around 80%. It binds to a glycoprotein called alpha-1 acid glycoprotein, which can be diminished in certain parts of life. Severe malnutrition will decrease the availability of this. So these people, when you give sufentanil, it's a greater portion of the unbound fraction will get into the bloodstream, which will increase the potency even more. And you get a very kind of effect that you don't want to have. Elimination after life is between fentanyl and alfentanil, and it undergoes a significant first pass pulmonary effects as well, just like fentanyl does, and a significant liver metabolism as well. The context-sensitive half-time for alfentanil is that you can see it's actually better on the first 8 hours. It does accumulate, but it accumulates at a slower rate than alfentanil or sufentanil. Beyond the 8 hours, alfentanil might be a better choice, but under the 8 hours, sufentanil will give you a more rapid awakening. The only one that would be the exception would be remifentanil. Clinical uses, we use 0.1 to 0.4 mics per kilograms for more rapid induction, earlier emergence, early extubation, and a longer period of analgesia with less respiratory depression. It does not cause histamine release. The side effects is that it causes chest rigidity, but more worrisome with this drug is it causes laryngospasm. So these people can be impossible to intubate. The first time I had muscle rigidity I ever saw was when a nurse anesthetist decided to give somebody 50 mics of fentanyl in pre-op to a patient. And before the patient transferred to the OR, the patient no longer was breathing. I mean, he was awake, but he couldn't breathe. His chest wall got so rigid. And the guy was waving at us. And I got called on the radio, hey, I got a problem here. And I get in there, and I try to ventilate, and the person's awake, and I can't ventilate. I said, induce him. He said, this is chest wall rigidity. And the guy said, he's like panicking. Gave him Diprovan, succinylcholine, and then broke it. And then ventilated the guy and got him out of it. But if you had waited too much longer, he would have coded. You had to induce him to stop this effect. So sufentanil can also have very, very potent effects on laryngospasm. Alfentanil is the next one. The potency is about 1/10 or 1/5 that of fentanyl. So it's 10 to 20 times more potent than morphine. But fentanyl comes in huge amounts, 500 mics per milliliter. The actual effect site equilibration is actually very, very rapid because it's very, very lipid soluble. The other thing that's the reason is for it is because its pKa is nearly the same as its normalized pH. So 90% of the drug is actually in non-ionized form, which makes it penetrate the CSF very, very rapidly. Alfentanil has 46 times smaller volume distribution than fentanyl because of its lower lipid solubility but higher protein binding. About 96% of it is metabolized in the liver by cytochrome P450-3A, and so you have prolonged effects with cirrhotic patients when you give alfentanil. So renal failure has no effect on the duration of this agent. Clinical uses is I use alfentanil in the outpatient center. The reason we don't use it anymore is because it's so expensive. It's so expensive, okay? It's ridiculous. If it was kept cheap, which it should be, and it would be actually a great agent. It's very good for rapid procedures like laryngoscopy or retrobulbar blocks. So alfentanil is useful for outpatient procedures, and you're looking at 150 to 300 mics per kilogram for a 45-second induction. You can give continuous infusions of 25 to 150 mics per kilogram per minute, and it actually has a less incidence of postoperative nausea, vomiting than all the other narcotics. The downside to it is it actually will affect dopamine release, and so it's really not a good idea to use in patients with Parkinson's disease because it's so potent. This is a nice potency ratio showing you that alfentanil is pretty weak in potency in comparison to fentanyl, and fentanyl is the most strongest. But the reason that alfentanil is so effective is because it goes on so fast that it then peaks down. What you see for your nausea vomiting rate, these different agents, the black is going to be alfentanil, fentanyl is the white box, and sufentanil. And the immediately PACU time is about the same. Retching and vomiting is a little less with alfentanil. Where you see the best benefit is when the person is later on, because at that point the medication begins to be broken down very rapidly. So you see that only the nausea vomiting rate is down to 12% instead of 33%, where you're seeing fentanyl and sufentanil. The reason I don't like using sufentanil is that the person's projectile vomit across the room. I've never seen any drug that does that. And nurses know when you're using sufentanil. They don't like you. Okay? Most nurses don't like getting hit with projectile vomiting that's 10 feet away. The splatter marks on your white coat's not really pretty. So be careful with sufentanil. Okay? This is why it's called, see the retching and vomiting, 22%. They're being really, I think they're being nice. It's much higher than that. But you see what's amazing to me is that people show this kind of numbers. 33% of patients are getting nauseous from these narcotics. What's the incidence of nausea with nitrous oxide? 7%. So how is it possible that we're still using narcotics? Because nitrous oxide is a horrible agent. It doesn't make sense. The thinking doesn't make sense. Okay? The narcotics are really bad. So what do you need to do in outpatients to prevent all this from happening? You got to stop giving the narcotics. And we now are doing that. How are we doing it? We're doing more blocks. A lot more blocks are being done. And as a consequence, the nausea vomiting rates continue to fall. Because if you cover it with local anesthetic has very little nausea vomiting potential. Versus these agents that are centrally acting do have nausea vomiting effects. We'll start on remifentanil next, and we'll finish up the last hour. Okay? The next agent we're going to talk about is remifentanil. Remifentanil is a very unique agent. Okay? It is very similar potency to fentanyl. Its equilibration time is very similar to alfentanil, which means it's rapid. It's structurally unique in the sense that it's broken down by ester linkage. So it's done by nonspecific plasma and tissue esterases. So it's not the same as succinylcholine that's broken down by a specific, what's called pseudocholinesterase. So if you have somebody with pseudocholinesterase deficiency, remifentanil is not going to be affected by that at all. Okay? So it's these nonspecific plasma and tissue esterases are out through the whole body. So it's one of those things that's really rapidly metabolized. So this is the only agent that you can give it and you don't have to worry about if they have any kind of liver damage because it doesn't matter. So this is the only narcotic that you actually have to worry, don't have to worry about it if their liver is not working at all. It's not affected by renal failure either. So the plasma and tissue esterases are very good about removing this drug very rapidly out of the bloodstream. The metabolism is unique. It gives it very significant brevity of action. It makes it a precise and titratable effect. It's non-cumulative and rapid recovery. It's actually too rapid. That's the biggest problem with this drug. If you give this person, if you give remifentanil to somebody who's having severe surgical pain and you stop it, it's like giving them Narcan. It's how fast it comes back. Okay? And what will happen is the person will wake up and be autonomically unstable, sympathetically driven, hypertensive, tachycardic, really dysphoric, not good. So that's why they call it rescue. They'll give rescue narcotics to these people, which means that they have to rescue them when you shut off the remifentanil with something like fentanyl. You have to add that agent back in to get them off and wake them up, be comfortable. So I think that's a real limitation to me. Now, if you want to use remifentanil for somebody that has severe pain, but once the pain is over, there is no more pain, then I think it's a great agent. So for laryngoscopies, where you're actually causing a lot of pain when the person is doing a laryngoscopy procedure, but as soon as they pull the blade out, there's no more pain, it might be the pretty good agent to use. And if you're trying to have somebody rapidly awaken from, let's say, intracranial surgery, I'm not a real fan of that because I'm still having to give rescue narcotics at the end. So, I don't know. It's very, very expensive. There's places for it, possibly. Where do I use it? I use it for long cases that require what's called somatosensory evoked potentials to be monitored. And I need to have a very stable anesthetic, but I can't use any volatile anesthetics in that situation. It suppresses my signal. So for that reason, remifentanil is really good. So in big spine cases, people are using more remifentanil. It has a very small volume distribution, rapid onset. You're looking at about 1.6 minutes to take effect. Elimination half-time is 6 minutes or less, which is very rapid clearance. Has 3 liters per minute clearance. That's amazing. Completely offset basically in 6 to 8 minutes after stopping infusion. And it really doesn't matter how long you've been dosing the medication. It wears off that fast. Okay? Clinical uses, cases with profound analgesic effect, like retrobulbar blocks, select patients at risk for suppression of transient sympathetic stimulation associated with laryngoscopy, also very helpful. Longer procedures and when a quick recovery is desirable. And if you're using it for somatosensory potentials or motor vocal potential studies, it may be a good choice. If you want to give 1 mic per kilogram IV, it only takes 60 to 90 seconds to induce somebody with it, and then you keep it going by giving an infusion of 0.5 to 1 mic per kilogram per minute over 10 minutes. This is the other way to induce somebody. One way is bolusing it. The other way is just creeping it up. I like creeping it up. I get less bradycardia. I get less hypotension with it. The biggest problem by giving the bigger bolus of 1 mic per kilogram IV is you get very, very significant bradycardia. I mean, I'm talking about heart rates go to 80 to 40. It's pretty impressive. And then their blood pressure drops on it. The disadvantages for surgeries that are associated with significant postoperative pain is that you have to give them rescue narcotics after discontinuing the remifentanil. And you also must not be, you must make sure that the IV is working the whole case. If you lose the IV, you're really toast. Okay? That person's will come right off that bed in about 6 to 8 minutes. And also, if you stop the infusion too fast, it can induce a severe nausea, vomiting. If you give it too quickly, then you cause, of course, depression of ventilation, decrease in blood pressure, and decrease in heart rate, like I told you before. The other agents that you may consider using is methadone. Methadone is a synthetic opioid. Usually it's given orally. This is a transitional drug to get you out of the hospital for somebody who's chronically requiring it. Opiates. Okay. Methadone, 20 milligrams IV, produces postoperative analgesia for lasting for 24 hours, which is pretty impressive. It does have depression, ventilation, meiosis, constipation, and biliary spasm as well. Now remember that the opiates basically decrease your overall anesthetic requirements. That's what the MAC bar is. So it does have a ceiling effect. The ceiling effect of your agents is for fentanyl, you have a ceiling effect of about 50% value. But if you look at the fentanyl, it has a much higher ceiling effect, which uses greater potency. Now, let's talk about the another way of thinking of things. Okay, so what we're talking about before is mostly about IV dosing, giving people IV agents. The bad thing about these agents is that they tend to get not to where you want it to in the sense of where the receptors are at. So we stepped it up by looking at where are the majority of the receptors, and the answer is in the spinal cord. So we can inject stuff in the spinal cord and give a lot less of the drug and get sometimes a lot less of the side effects, supposedly. Of course, it didn't work out perfectly like that. But what was done was basically we started doing what's called neuroaxial opiates. Neuroaxial opiates means that we're administering them either in 2 places, either the epidural or the spinal, also known as subarachnoid, also known as the interthecal space. It's really for management possibly of acute or chronic pain. The opiates bind the mu receptors found in the substantia gelatinosa, which is in zone 2 of the dorsal horns. The benefits of neuroaxial is associated with sympathetic denervation, so you get less of that. You get less skeletal muscle weakness, and you do not get associated loss of proprioception. Analgesia is dose related, so the higher the dose, the more analgesia you get. Okay. The actual epidural dosing is 5 to 10 times more than the subarachnoid dose. Okay. So when you're giving Duromorph epidural, you're giving usually between 3 to 5 milligrams in the epidural space, versus if you're giving Duromorph, which is morphine preservative-free, in the intrathecal space, the spinal, you're giving 0.1 to 0.3 milligrams. Okay? So it's really significantly smaller. Somebody forgot this one time, okay, and I had a resident give somebody 10 milligrams in the spinal fluid space of Duromorph instead of giving 0.1 milligrams. Whoa. Didn't you have a clue when you're giving the 10 cc's? That didn't make sense when you put it into the spinal. I mean, spinal, you're only giving usually 2 cc's of fluid. You're not giving 10 cc's of anything. Okay? Well, it was kind of interesting. It does cause somnolence quite a bit. Okay, we had to put them on a Narcan drip overnight and kept them in the ICU, watching them for 2 days to make sure they didn't go apneic on us. And the person tried several times, but we just kept upping the Narcan to reverse the effect. So, pretty frightening. Don't make those kind of mistakes. Analgesia is specific for visceral rather than somatic pain, so in that sense, it's kind of good for intra-abdominal surgery. And it decreases your MAC for volatile anesthetics. Although that's controversial, some people say it doesn't. I think it does personally because I've seen that you require less, but it depends on how fast the binding effect is taking place. The binding sites don't bind quickly. It takes time depending on which agent you're using. If you're using the lipid-soluble agents like fentanyl, the binding is very, very fast. So the effect is almost immediately after you inject it into the spinal fluid space. But if you inject something like Duromorph, which is more water-soluble, it tends to be a happy guy sitting inside the CSF, and it doesn't bind to receptor sites. So you can see a prolonged effect before the effect is taking place. And sometimes it happens in the middle of the case. It could be even at the end of the case. So you don't see really any changes in MAC value. And that's why you may see that differences in the studies. It really depends on when you give it and which agent you're giving. If you're looking at the epidural, of course, you're looking at dosing it out here above the dura. Okay, you're injecting it between the ligamentum flavum and the dura itself. And you're injecting large volumes of solution. And what you're expecting to do is that you're expecting it to go down and then penetrate into the CSF and eventually get into the substantia gelatinosa. So it takes a little bit of time to say the least when you give Duromorph out here, and the amount that you have to give here is 10 times greater than if you were to give it in the spinal fluid space. Basically, the epidural is about 1 millimeter away from the cord, and it's separated by 2 meninges of dura and arachnoid. The pia is up in the brain, not down here at this point. Opiates in the epidural space diffuse through the epidural fat. Then the dura eventually penetrates through that, and then it binds to the mu receptors in the spinal cord. The other thing that epidural injections will do is that it will also go right next to the epidural veins. So the medication will be absorbed into your bloodstream. Okay? The more lipid-soluble the agent, the more rapid the transfer through into the bloodstream will take place. Okay? So actually some people will tell you that there's no difference between IV fentanyl and epidural fentanyl. And I would tend to agree with them because if you look at the plasma concentrations of both, if you gave equivalent doses in the epidural space or the IV space, the concentrations are almost the same. They literally mimic each other. So there's a real benefit to injecting epidural fentanyl instead of just injecting it IV. No, if you're putting a needle in that space just to inject fentanyl, it makes no sense. If you inject a local anesthetic, you want to mix in, throw the fentanyl with it, okay, as you could give it IV too, and it would make no difference. But it shouldn't be any problem if you give it back there either. So the poorly lipid-soluble agents like morphine will result in slower onset of action and a longer duration of action because it's water-soluble. The lipid-soluble, on the other hand, there's really going rapidly. There's no real difference. The most common place that we put epidurals, of course, is in the lumbar area because we're staying away from the spine, from the spinal cord itself. We're looking at the lumbar space. Space is fairly safe because the spine is perpendicular here. Remember, the spinal cord ends at L1, and the spinal nerves, if you touch them that are further down, are a little bit more resistant to injury. The actual rate of transfer is dependent on lipid solubility. The more lipid soluble the drug, the better penetration to the CSF. Morphine is because it is poorly lipid soluble. It takes a long time to peak. It takes 15 minutes to peak. And CSF morphine levels will peak in about actually 1 to 4 hours. So that's what I was telling you. If you give morphine and you expect the Duromorph to work right away, you're in for a big surprise. You're looking at maybe 1 to 4 hours before peaks. Okay, less than 3% of the epidural dose actually reaches the CSF. So it's a very small amount. Now the downside to it is once the CSF, the actual morphine penetrates into the CSF, it begins to float in the CSF. So part of it binds to the actual spinal cord, but part of it is still floating in the CSF. Even though it's 3%, that stuff is really potent. Okay? Now what happens is as your CSF circulates, which it does, okay, because you're breathing, and your intropulsatile pressure of your brain will make the CSF circulate. So the CSF begins to move upwards to hit the brain eventually. If you have enough concentration of morphine that gets into your medullary area of your brainstem, you can cause apnea and cause death. So Duromorph is not safe. It's a very, very dangerous drug. It is not something you would ever give somebody as a single shot dose and then send them home. You will have a lot of dead people if you do that. Okay? You need people that are highly trained to watch these people post-op. And I'm talking about good nurses with apnea monitors and pulse oximeters. Okay? If you give people oxygen afterwards, you will mask the hypoventilation, and the patient will actually go apneic and die. Okay, so you have to sort of make sure that everybody's watching their respiratory rate and make sure that they're picking up on it. If you're looking at the other agents, which are the fentanyls, sufentanols, which are lipid-soluble, they're very lipid-soluble in comparison to morphine. Fentanyl is 800 times, and sufentanol is 1,600 times more lipid-soluble than morphine. So as soon as you inject it into the space, it's rapidly going to transfer to the fat. As soon as rapidly through it goes to the dural membrane, and literally within 5 to 10 minutes, fentanyl peaks. If you look at sufentanol, because it's so much more potent, it peaks in 2 minutes. So pretty quick. It's going to have a rapid effect on the spinal cord, to say the least. CSF concentration peaks in 20 minutes versus sufentanil peaks in 6 minutes. The other thing, the molecular weight may also play a role in the transfer rate. The bigger the molecule, of course, the less it transfers. Epidural administration of fentanyl, sufentanil, and morphine are similar to eye injections of equivalent doses. Epidural epinephrine with opiate will decrease systemic absorption. Does not really decrease the diffusion of morphine into the CSF. What it does is it really helps with the lipid-soluble agents to keep them more in the epidural space. So a lot of us will use the epinephrine for that situation. Now let's go into the spinal injection. Spinal administration of what's called the intrasubarachnoid or intrathecal injection means that you put the needle into the actual CSF and inject the medication in there. Now that means the medication has to be in a lot lower concentration because it does not have to penetrate to the dura. You've already done that for it. You put the needle through the dura to do that. Okay? The downside to that, of course, is now you're increasing the risk of the person developing a post-dural puncture headache. Okay, that's the downsides to do it. The benefit is that you're going to get a lot less volume to inject in there, and you're going to have a much more potent and a greater density effect when you inject medicines into that fluid space. Now, what we're dealing with when we're doing fluid-to-fluid interactions, we're no longer dealing with just volume. We're dealing with porosity, the porosity of the compound. If you give something that's really heavy, it stays down. If it's light and fluid, it goes up. The way I think about porosity is think about water with vinegar or oil on it, okay? Or think about when you have a drink with multiple porosities, like a Manhattan. Okay, Manhattan says it's got 3 different layers or 5 different layers of alcohols. All those alcohols have different porosity. Okay, so if you give something that has a low porosity, it tends to go upwards. If it has a high porosity, it tends to sink. Okay, subarachnoid lipid-soluble agents like fentanyl get rapidly absorbed into the spinal cord, and the good thing is that once it binds to the spinal cord, it is no longer going anywhere. So these people don't get delayed respiratory depression. On the other hand, if you give intrathecal morphine, it does not get absorbed intravascularly, but it also floats in the CSF, so that person has a much higher chance of developing delayed respiratory depression and death. So these are the people that you have to worry about. What we do is we add 2 things. When we're doing a spinal now, is we add a local anesthetic, which is to knock out the nerves by sodium channel suppression. Then we add fentanyl, which is a lipid-soluble agent, to decrease the acute onset of pain, and it's going to be very predictable about how it binds. So we have usually fentanyl 20 mics, and then we add on top of that 0.2 milligrams of Duromorph, which is morphine. And the morphine is there for the prolonged effects, long duration of action of 24 hours, pain control, versus fentanyl will only work for about 6 hours or less. Okay? If you use epinephrine, it increases the density of the block because epinephrine itself will cause an effect. And it does not affect intravascular absorption. Prolongs the duration of action of lipid-soluble agents, yes. And it does not alter the duration of highly protein-bound local anesthetics. Dosing of spinal opiates is mixed with local anesthetic, which I just talked about. You add epinephrine to increase density, which also has that effect of changing the porosity. Usually you give anywhere between 0.1 to 0.3 milligrams, depending on the age. You will see that we actually have protocols for this, and it's based on age. After the age of 78 or something like that, or 75, we're down to 0.1 milligrams of Duromorph. Works very effective if you don't want to go in the higher doses and we don't have problems. And then we use 20 mics of fentanyl to enhance it to the block. Side effects is just like anything else. It's a narcotic. So you're going to have the side effects of binding to multiple receptor sites. So you're going to get pruritus is the most common thing, and people get this kind of localized to the face, neck, and chest. It really can be really irritating. It's not due to histamine release. It's just simply to cephalad migration of the narcotic. And it can be relieved by giving that person Narcan, but give it to them low doses. Usually you dilute it in the IV bag and just give it slowly. You can also get nausea, vomiting. If a person tells you that they're morphine allergic, please do not give them morphine in their back. You're asking for it. Now you're going to have a depot effect drug, and now they're going to have anaphylaxis for 24 hours. Not smart. Okay? So don't do that. Okay? Urinary retention can also be a real problem, especially in young males, because of the interaction of the actual sacral spinal cord with the opiate receptors. You get also respiratory depression is the most worrisome and the most serious side effect, which only occurs in about 1% of patients. It gets systemic absorption, cephalad migration into the brainstem, which causes the person to stop breathing. The depression can be is early respiratory depression within 2 hours. It's due to lipid-soluble agents being reuptaken via the IV. Fentanyl is most likely the agent of doing that, and it's not likely caused by morphine. On the other hand, the late respiratory depression is not due to the lipid-soluble agents, but rather due to water-soluble opiates like morphine, and actually this is one that travels all the way up the brainstem to penetrate that and cause a ventilatory depression. More respiratory depression beyond 24 hours after. There's no more respiratory depression beyond 24 hours. The biggest risk factor is the period between 12 to 18 hours. That's where the biggest risk is at. 6 to 12 hours when it starts to happen, but really 12 to 18 is when it starts going into apnea. So, what you see is your gradual decrease in respiratory rate, although this is not really reliable, at least by some of the book comments. You do see a gradual decrease in minute ventilation, which is very reliable. So people are not really watching is what they're doing. Eventually you see a decrease in saturation. This is really poorly sensitive to hyperventilation and hypercarbia, and can be masked by low-flow nasal cannulas, which can be a problem. So pulse oximeters can basically not pick up that you're hypoventilating until it's too late. You see increased somnolence, usually due to hypercarbia. Then you see an initial increase in blood pressure. Eventually apnea follows and you get cardiopulmonary arrest. What increases the risk is use of other IV opiates or benzodiazepines. Coughing may actually increase the cephalad motion of CSF upwards. Morbid obesity also increases the risk, especially if you have somebody with Pickwinian syndrome, very high risk. And that's one thing that excludes you immediately if you're an OB of getting Duromorph if you're over 300 kilos. So you don't get this drug. We actually had 2 patients die about a year and a half ago, 2 years ago, from postoperative apnea. And the first time, the first person that died, immediately the ICU doctors turned to us and said, "You caused it with your spinal." And I said, "You were right, we did the spinal." I said, "Well, you're accusing us now." I said, "Well, it's from the opiates that you added to it." And I said, "We didn't put any in." And all of a sudden, he had to shut up. So immediately, we got blamed for something that we didn't do because the patient was over 350 kilos, and it was out of the exclusion of high risk. So I'm glad we did, because otherwise we would have been involved in a lot of the lawsuit for something that we have no responsibility for. So what's happened as a consequence is we've increasing the observation of these people even closer, This is not, and OB is becoming more and more high risk. Women, for some reason, are increasingly become more morbidly obese. We're looking at women weighing 350 to 400 kilos when we're delivering them. It is very high risk anesthesia. And we're putting needles in that are twice the normal distance to get these spinals in. So it's not a joke. Now what ends up happening is the CSF space gets smaller and smaller because the fat around it begins to squeeze it from the outside. So when you inject the medicine, it tends to travel faster and higher. And that's really concerning because you can get now a very high risk of getting apnea in these individuals. That's why we basically excluded anybody over 300 kilos. They're done. We're not going to do it. And I've had several people call me and be mean to me, but it's like, you know what, I'm not going to cause anybody to die. And nobody dies from narcotics because, nobody's going to die from pain because we have other ways of controlling it with IV medications. So they don't want to be bothered. But you know what? We can't cause people to die from this agent. So morphine is very, very dangerous, and you've got to have a lot of respect for it. If you're working in a hospital, you don't trust the nursing staff, you can't do this. You've got to trust your nursing staff to do this job. And I do trust the nurses here. But I also trust them that I train them to make sure that they're doing it right. Okay? If you don't train people properly and you don't put protocols in, this can be really dangerous. So if you see, when you go downtown, you see how it runs so smooth and you see no problems, that's because the system's running like a machine. It's been well oiled. It's got all the protocols put in. You don't want to take this and go to a small little hospital where nobody's ever seen Duromorph and you start injecting it, and then people get to out there in the floor and nobody's watching them, and they say, "What? Duromorph is what?" And Duromorph used to be told. We asked 7 years ago when we started instituting this. People said, "What is Duromorph?" They didn't even never heard of it. So you got to train people. Take your time. And some of these lecturers actually come and went out to the nurses so they got trained about this stuff. The side effects, sedation is dose related. Okay. CNS excitation can also you can get skeletal muscle rigidity. You can get also, bad thing is viral reactivation. That's a real problem. So if you have somebody with chicken pox or what's called a herpes virus, and you give epidural to them, you can actually induce it again. So you can get the shingles again. So that's one of the downsides of giving the narcotics to people. Okay, and you see it 2 to 5 days after injection. Then we'll stop here and finish up on this, which is the opiate agonist, antagonist, and the antagonist. This is a very brief discussion for about 8 slides, and I'll be finished. There's 2 key points on this. Is the agonist, antagonist are really what are they indicated and how are they limited. The antagonist is why we actually use them, which is reversing of either agonist or agonist-antagonist. The good thing about antagonists is that if you give it slowly, you can competitively push it off and not knock out all the analgesic effects. If you give it too strong, it will compete and push off all the analgesic effects of the narcotic, which is one side to it. Now, the opiate antagonists or agonists are these: pentazocine, butorphanol, albuphine, buprenorphine, benzazine. Nubane is what Swiss and Stadol. OB loves this crap. I hate this stuff. Okay, this stuff is like, might as well. It sedates people, and they don't complain, but they're still having pain. And then when you take them to the OR and you try to get them comfortable, nothing works because it's an antagonist. So you can give fentanyl, and you see, why is the fentanyl working? And it's because they gave them a bunch of Nubane or Stadol. Okay? And trust me, everybody that's gotten Stadol, they look whacked out. Okay? How many people had Stadol in this room that had OB? Nobody? What did it feel like? What's that? I can't hear you. Yeah, it felt like you were out of it. Were you able to communicate to people? Okay, well, that's good. Most of the time when you give enough Stadol, the nurses love it because you no longer talk. Okay? So they think that you're not having any pain anymore. Okay? If you shut the person up, they're no longer really having pain, right? And it doesn't work that way, sorry. Okay? You can have a lot of pain with Stadol. Okay? Because it only covers moderate discomfort. Okay, so they bind to mu receptors and produce limited response or no effect. It's also a partial agonist and also partial antagonist. So the downside to it is, let's say you give that person, let's say that person's gotten blotted, right? And they're semi-comfortable, but want something more. Now you add Nubane. Now you actually, even though you're adding another narcotic, this is an agonist-antagonist. It begins to push off the Dilaudid that you had on board, and now this person begins to have even more pain, even though you're giving more medication. And then can you get them comfortable again? The answer is you can't. You can add more Dilaudid now, but then you now run the risk of, if the antagonist wears off before the Dilaudid begins to wear off, you can go into apnea. So this is really not a good agent to be using, I don't believe. Either use one agent, use it properly, which is the agonist, and sort of stay away from the agonist-antagonist. These drugs really have a ceiling effect, and yes, they have low ventilatory depression, but they don't damn work, so what good is it? You know, I'm not a fan. Okay? Limited use produces a very limited level of analgesia. Ceiling effect's not good. Can be used in combination with other agents such as nitrous oxide or benzodiazepines if concerned about respiratory depression, but you need analgesia. You have to cover it with other agents. And these combinations will not be sufficient for surgical anesthesia, which then basically makes it ineffective for what we do. Okay? And no anesthesiologist, no nurse anesthetist will ever pull out Nubane and use it, okay? Because they've been burned too many times. And trust me, when the pharmaceutical companies came out with this stuff, they told, well, this stuff works great. You don't have any worry about respiratory depression. You just give it, you just give it all you want, and the person never stops breathing. And I said, do they get comfortable? Well, they do. Sort of, yeah. Until you talk to a patient and you find out that they're really not comfortable, but they really can't talk about it because they're sort of out of it. So, it does partially reverse an agonist. Its goal is to reverse some of the unwanted effects of morphine, meperidine, fentanyl, all the other agents, okay? You can't titrate it, and that's really what makes it bad. You really cannot titrate it. It gives you, and it varies so much between individuals that you really don't know where you're going to be. It may result in sudden pain, which can invoke a severe sympathetic response leading to an increase in blood pressure and heart rate. So I don't mix these two agents together. All have high affinity for opioid receptors, which result in displacement of agonist. And after displacement, the antagonist does not activate. The receptor prevents a pure agonist from activating it, which is the downside to it. Now, these are my good friends. I tend to use Narcan. That's my favorite friend of this family, which is the antagonist. This is the only one I use. I don't use the naltrexone or nalmefene. I only use naloxone. Okay? That is my only agent that I've ever used in clinical practice, and I'm not likely to ever change it. So I'm going to only talk about naloxone. So I'm going to be sort of biased. It's basically great for treating opiate respiratory depression, especially if the patient is in a post-operative period. If you give somebody naloxone, you are obligated to tell the person who's taking care of them next. You will kill somebody if you don't. If you think you're going to be slick and give somebody Narcan to somebody, and then you're going to be able to hide it, that you gave too much narcotic, and you can give that patient to the recovery room nurse and everything's going to be fine, you're going to kill somebody. And trust me, when it happens, it's going to come back on your shoulders. So if you give somebody Narcan, you just got to fess up to it. It isn't a bad thing. It just means that you gave too much narcotic. And it could be the person is very sensitive. But you've got to tell the next person who's in charge of that patient. So they don't keep adding, because what will happen is the person will start waking up and all of a sudden begin to say, I'm hurting. And the Narcan's still on board. So the nurse will give morphine, which is a long-acting agent. Okay? And now the Narcan wears off because it's short-acting. And then the peak effect goes boom and knocks them out. Now they're apneic. So instead, what you do is you go more gingerly. If you have somebody who is complaining of pain that has Narcan, you go with really low doses, and you tell the person you're going to have to sort of suffer for it for a little bit. Okay? And that's unfortunate, but that's the only thing that's going to keep them safe. Do not add a bunch of narcotic after you've hidden with Narcan. You've got to wait for the duration of action to terminate a Narcan to make sure then you can add the narcotic all you want, and you'll be safe. How long is the duration of Narcan? It doesn't last very long. It lasts about 45 minutes. So you just say, okay, when you give it, in 45 minutes afterwards, you can start giving more narcotics safely without really bad effects. Okay? Now, should you give everybody Narcan? The answer is absolutely not. It should be very selective on who you're using it on. How many times have I used Narcan in my career? +1, just the other day. But it wasn't my fault. Okay? The sixth one was a patient that they take to the cath lab. They'd given her 20 milligrams of morphine, 100 milligrams of Demerol, 5 milligrams of Versed. What else did they give her? And then they gave her, the last thing they gave her was Zofran, 4 milligrams of Zofran. So the person that was, I got called for this code. This person wasn't breathing. They were in recovery. And I got there, and this lady is completely out. Saturation's 80%. Immediately slapped the mask on, bag her, and I started saturations back up to 100% pretty quickly. So, okay, so I asked what's going on. I heard 100 milligrams of Demerol, 10 milligrams of morphine, 5 milligrams of Versed. I said, okay, we're going to give Narcan. Okay? So here comes the other person in charge, which was the person who was telling the nurses to give all this stuff. He said, no, it's a Zofran. Because that's how much negativity Narcan has. The empirical association is if you give somebody Narcan, is that you've overdosed that individual. And it becomes a code that goes into the computer that you have had to give it to somebody because you've overdosed the patient. But you know what? Who cares? You treat the patient and you get over it. We gave Narcan, and sure enough, the patient woke right up. And I said, obviously it's not the Zofran. Okay? Zofran doesn't do that. Okay? So, what you'll see is the other thing you can use Zofran for, and I have quite a bit actually, is when people are itching. They're terribly itching from neuroactive opioids. They're just driving you crazy. They're coming out of their skin. You just put 1 amp of ampule of Narcan and 1,000 cc's of normal saline or LR and run it to 50 cc's an hour, and right away the itching stops. But the pain levels are totally controlled still. So it works pretty well. Okay? That's part of our protocol, actually. If you look at our protocols in anesthesia, everything is written ahead of time. If you guys want to steal that and take it to your new site, hey, man, there's a lot of work went into it. Go ahead. And that's part of the benefits of being a student. You always take what you were learned, take it with you, so you don't have to reinvent the wheel if it works. Okay? Or modify it if you want to when you get to the new site. Narcan usually comes in 1.4 milligrams per cc vials. The way I dilute it is I put it in 10 cc's to make myself 0.04 milligrams per cc, which is 40 mics per cc. And then I usually dose it 1 to 2 cc's at a time. And then I basically wait about 1 to 2 minutes for the effect and see if the person starts coming out of it. And I just do it slowly enough, as long as I can ventilate, I do it slowly enough that the person comes out of it, now is talking to me, and is still comfortable. Okay? Will it take the euphoric effects of the narcotics? Absolutely. You'll terminate their buzz? Absolutely. But at least you got them spontaneously breathing, and you're not having them so much in pain that they're causing an oversympathetic discharge. It really has a short duration of action. The maximum is about 45 minutes. So you need to have supplemental doses if you're going to give it to somebody. Anybody you give Narcan, they have to be either ICU or PACU, and they have to go to ICU or PACU. You're forced to. You have to monitor them closely. This is the person you cannot afford to walk away from for 30 seconds. Okay? It has a very high pass effect by the liver. Nausea, vomiting may be a problem. It depends on how fast you give it. If you give it really, really fast, the nausea vomiting rate goes through the roof. Nothing like projectile vomiting at you, and especially when the vomit starts filling up your mask. Not good. Okay? So you better have suction available when you're using this. Giving naloxone over 2 to 3 minutes decreases the incidence of nausea vomiting. That's why I said giving a dose. Fortunately, vomiting occurs after or simultaneously with awakening, which ensures protection of the patient's airway, which is true. But it doesn't mean that you shouldn't have suction ready to go and make sure that if the person starts vomiting, what's the first maneuver you're going to do? Turn them on their side. Turn them on their side. Let the vomit come out of the mouth. Do not lay them flat. Do not put the mask on top of them and keep the vomit all in. I saw somebody do that one day. I said, what the hell are you doing? Release the vomit. It's like, like, okay, you know, come on. So think things through some days. Just amazing. The last one I'm just going to very, very briefly talk about. I'm not going to even ask you on this in the test. But I thought, I've never used this drug myself, so the dose is very similar. It's 0.25 mics per kilo over 2 to 5 minutes. The primary advantage of nalmefene over Narcan is the longer duration of action. The half-life is 10.8 hours. I don't think that's really a benefit. If I'm giving somebody Narcan and they're having surgical pain after 45 minutes, I know I can safely give this and I won't have any problems. But if I give nalmefene to this individual, I'm 10.8 hours into half-life. Well, that means I can't give anything until the next 10 and a half hours. So, not a good agent, okay, for me, that we're using in the operating room. So, that's why don't even bother when it's called Revex. It reverses all your narcotic effects. So, I just use Narcan, okay? That's it for today, folks.